Welcome back to AudioBoards. Today we are diving into ICU sedation. First, let's clear the air. Historical reliance on deep, continuous sedative infusions was a major iatrogenic driver of poor outcomes. Modern critical care demands that we treat sedation as a highly titratable, potentially toxic drug class with severe systemic consequences. The PADIS guidelines emphasize that keeping a patient chemically comatose without a strict physiologic indication is an outdated practice that directly prolongs mechanical ventilation, triggers diaphragmatic atrophy, induces ICU-acquired weakness, and skyrockets the incidence of delirium. Our baseline framework must shift to analgosedation, an analgesia-first approach. Untreated pain is the primary driver of agitation, ventilator dyssynchrony, and sympathetic surges in the critically ill. When an intubated patient is thrashing or fighting the ventilator, the immediate clinical reflex shouldn't be to look at the propofol rate. There has to be a rigorous differential diagnosis of agitation run through first. Is it pain? Is it acute hypoxemia or hypercapnia? Is it a mechanical ventilator issue, a kinked endotracheal tube, or acute urinary retention? Could it be severe metabolic derangements like hypoglycemia or perhaps acute withdrawal states? Sedation should only be initiated after these physiologic emergencies are ruled out or addressed. When we do sedate, the default target for the vast majority of mechanically ventilated adults is a light sedation strategy, specifically a Richmond Agitation Sedation Scale, RASS, of 0 to -2. At this depth, the patient is calm, cooperative, easily arousable to voice, and capable of participating in early mobilization and daily spontaneous breathing trials.
Exactly, and maintaining that light sedation target really dictates the day-to-day trajectory of these patients. But we also have to recognize the narrow subset of clinical indications where deep sedation, RASS -4 to -5, is actually therapeutic and mandatory.
Right. Those exceptions are strictly limited to severe ARDS, experiencing profound ventilator dyssynchrony. Despite optimization, patients requiring continuous neuromuscular blockade, refractory status epilepticus requiring EEG-guided burst suppression, and acute neurocritical care scenarios with severe traumatic brain injury or refractory intracranial hypertension, where lowering the cerebral metabolic rate is vital. Outside of these conditions, deep sedation is an unforced error.
Let's dissect the objective scoring systems we use to operationalize this at the bedside.
Yes, we cannot manage critical care physiology based on subjective impressions. If a patient is neurologically intact and communicative, the 0 to 10 numeric rating scale is preferred. If they are non-communicative or deeply ill, we rely on validated behavioral metrics. The two most robust tools are the Critical Care Pain Observation Tool, CPOT, and the Behavioral Pain Scale, BPS. CPOT quantifies 4 domains: facial expression, body movements, muscle tension, and compliance with the ventilator or vocalization if extubated, with each scored 0 to 2. A CPOT score greater than 2 signifies clinically significant pain that demands an analgesic intervention before any sedative is titrated. BPS utilizes facial expression, upper extremity movement, and ventilator compliance on a 1 to 4 scale, yielding a composite score from 3 to 12.
Let's move into the advanced pharmacology of our primary ICU agents.
For analgosedation, fentanyl is our first-line opioid workhorse because it is highly lipophilic, has a near instantaneous onset of 1 to 2 minutes, and lacks the histamine release seen with morphine, ensuring excellent hemodynamic stability in shock states. Though that lipophilic nature is a major double-edged sword. During prolonged continuous infusions, fentanyl saturates peripheral adipose tissues. Once those tissues are saturated, the drug slowly leaches back into the central circulation, leading to severe drug accumulation and a highly unpredictable, delayed awakening window that can stall extubation plans for days.
Precisely. And if a patient has acute or chronic renal failure, morphine must be avoided because its active metabolites accumulate rapidly, causing prolonged narcosis and respiratory depression. Instead, choose hydromorphone or fentanyl. If the clinical goal requires frequent, unconfounded neurologic assessments, such as in complex neurotrauma or weaning trials, consider remifentanil if available.
Yes, because it is metabolized rapidly by nonspecific plasma esterases, it possesses a unique 3 to 5 minute half-life that remains completely independent of infusion duration or renal/hepatic function. You turn it off and the patient is fully testable within minutes. The downside is its high cost and the fact that its ultra-short duration means pain control drops to zero instantly if the infusion is interrupted.
When it comes to dedicated sedatives, the PADIS guidelines state a strong preference for non-benzodiazepine regimes, propofol or dexmedetomidine, over benzodiazepines due to clear reductions in mechanical ventilation duration, delirium rates, and ICU length of stay.
Propofol is a potent GABA-A receptor agonist that provides excellent rapid hypnosis, anxiolysis, and amnesia while lowering intracranial pressure by suppressing cerebral metabolic demand. It features ultra-rapid pharmacokinetics, allowing patients to awaken within 5 to 10 minutes after stopping short-term infusions. However, you must respect its side effect profile. Propofol induces systemic vasodilation and mild myocardial depression, which can precipitate severe cardiovascular collapse in patients with profound hypovolemia or septic shock. Furthermore, because it is formulated in a 10% lipid emulsion, prolonged infusions beyond 48 hours mandate close monitoring of serum triglyceride levels to avoid hypertriglyceridemia-induced pancreatitis. We must maintain a high index of suspicion for propofol infusion syndrome, PRIS. PRIS carries an extremely high mortality rate and is typically triggered by high-dose infusions exceeding 4 mg per kilogram per hour, running for more than 48 hours, especially in the presence of concomitant catecholamine infusions, glucocorticoids, or severe neurological injury. The classic presentation includes refractory metabolic acidosis, rhabdomyolysis, hyperkalemia, acute kidney injury, elevated creatine kinase, and progressive cardiac failure manifesting as fatal bradyarrhythmias. If PRIS is suspected, the propofol must be stopped immediately and aggressive supportive therapies initiated.
That is an essential catch on PRIS. When propofol's hemodynamic or metabolic profile isn't a good fit, how are we optimizing dexmedetomidine or leveraging ketamine in advanced weaning and shock algorithms?
That brings us to our next tier of agents. Dexmedetomidine is a highly selective central alpha-2 adrenergic agonist that works by suppressing central sympathetic output from the locus coeruleus, creating a unique state of cooperative sedation that mimics natural non-REM sleep. Unlike propofol or benzos, patients on dexmedetomidine remain easily arousable. They can awaken, follow commands, participate in physical therapy, and then drift back to sleep when undisturbed. Crucially, it causes zero respiratory depression, meaning you can safely continue the infusion through spontaneous breathing trials and even post-extubation. However, its limitations are clear. Its primary adverse effects are dose-dependent bradycardia and hypotension due to its sympatholytic mechanism, which can be severe in patients with pre-existing conduction disease or profound hypovolemia. Additionally, it lacks the GABAergic potency required to induce deep sedation. If a patient has severe ARDS with ventilator dysynchrony or requires paralysis, dexmedetomidine will fail to provide adequate sedation depth. This is where ketamine has emerged as an invaluable tool in the modern ICU. Operating as an NMDA receptor antagonist, ketamine provides a powerful combination of dissociative sedation, amnesia, and profound analgesia while preserving the patient's intrinsic respiratory drive. Its hemodynamic profile is entirely unique. Rather than causing cardiovascular depression, it stimulates the sympathetic nervous system, leading to a transient rise in heart rate and systemic vascular resistance. This makes it an ideal sedative analgesic adjunct for patients in refractory septic shock or trauma who cannot tolerate the vasodilatory effects of propofol. Furthermore, its potent opioid-sparing effect can dramatically reduce cumulative opioid requirements in highly tolerant or severely burned patients. Just monitor closely for sialorrhea, which may require anticholinergic therapy, and emergence delirium or hallucinations.
And remember, the old dogmatic contraindication that ketamine dangerously elevates intracranial pressure has been soundly debunked. It can be used safely in neurocritical care, provided that ventilation is controlled. Lastly, let's talk about benzodiazepines like midazolam and lorazepam.
In routine mechanical ventilation, benzodiazepines are no longer first line. They exhibit highly unpredictable pharmacokinetics in the critically ill, accumulate heavily in hepatic dysfunction and obesity, and represent one of the most potent, independent, modifiable risk factors for ICU delirium. Continuous use must be restricted to specific mandatory indications: alcohol withdrawal syndrome, severe benzodiazepine withdrawal, active seizure management, or refractory status epilepticus.
To wrap up our clinical execution, how are we structuring the daily routine to ensure we're actively liberating these patients from the ventilator?
It all centers around the ABCDEF bundle. Every morning, unless strictly contraindicated by active seizures, open paralytics, severe ARDS, or profound hemodynamic instability, a spontaneous awakening trial (SAT) must be performed by turning off all continuous sedatives. Once the patient awakens and proves neurologically stable, they must immediately transition to a spontaneous breathing trial (SBT). Pairing SAT and SBT sequentially is one of the most evidence-based interventions we have to decrease ventilator days and maximize extubation success. Tie this to active routine delirium screening using the CAM ICU or ICDSC, non-pharmacologic sleep optimization, and aggressive early mobilization.
Remember, the ultimate goal in the ICU is not to maintain an undisturbed, motionless patient. It is to use the absolute minimum dose of sedation necessary to keep the patient safe, comfortable, and actively progressing toward liberation and recovery.
Thanks for listening to AudioBoards. Stay tuned for more educational content in our next episode. The views and opinions expressed on the AudioBoards podcast do not necessarily reflect those of our employers. This podcast is for educational purposes only and should not be used to diagnose or treat any medical conditions. It is not a substitute for professional medical advice. Always consult a qualified, board-certified healthcare provider for any medical concern.